Hey guys, this is Dr. Marva, and today we shall be talking about a very relevant topic for today and an important one as well, oxygen therapy for a patient of COVID-19 pneumonia. And I'll be explaining to you the step-up algorithm. The point of the discussion or the objective of the discussion is to sensitize you to what are the modalities available and how would you change these modalities. If a patient is desaturating, what is the modality that you will use and for how long? And once he improves, then how would you step down as well? So first and the foremost, we need to touch base and understand the term acute respiratory failure because I'll be using this terminology multiple times. So do remember this mathematical formula, PO2 divided by FiO2 ratio, that is partial pressure of oxygen that you can get from the ABG report and fraction of inspired oxygen. If this turns out to be less than 300, then we call it acute respiratory failure. Now lots of you who might be working in periphery, you may not be having access to a ABG machine. In those circumstances, you can even use the SpO2 value, and if you divide the SpO2 of the patient by FiO2, if this value turns out to be less than 315, we will say that patient is in acute respiratory failure. Lots of time during the course of this discussion, I'll be using terms like P by F ratio, which I have now explained what I mean by that. I'll be using terms like S by F ratio. I have explained what I mean by that. That is SpO2 divided by the FiO2 ratios. So the point of this discussion is to sensitize you to how to go about managing the patient. From the exam perspective, not only are you supposed to know these mathematical values, but you are also supposed to be very clear about the fact that in COVID-19 pneumonia, the patient lands up in your casualty with type 1 respiratory failure. Now, point is that in these patients, hypoxia is the prominent problem, but you would have seen a lot of these patients may not be complaining of breathlessness. In fact, it is the relatives who are saying that my father or my mother's SpO2 is reduced, but patient himself is not saying that doctor, I'm having shortness of breath or I'm feeling so suffocated. So you are anyway familiar with the term happy hypoxia. So I want to highlight what I mean by the word happy hypoxia here is that the person is not complaining per se of any breathlessness, shortness of breath, but at the same time the oxygen saturation of the patient is substantially low. Now we go to step 1, and in step 1 we need to understand what is the cutoff beyond which you would go in for this intervention. So multiple choice question wise as well as for your knowledge, if you are having a patient admitted right now or presented to the emergency department, the respiratory rate of the patient is in the range of about 20 to 24 per minute and the SpO2 of the patient is between 90 to 93. In these circumstances, you obviously have to consider step 1. The GCS of the patient would be 15 on 15 and the blood pressure and the vitals of the patient are at the moment maintained. So you are going to be using at the moment a nasal cannula to deliver oxygen for this patient, and you can use an oxygen concentrator, which is currently, as the government has imported multiple oxygen concentrators, things have become relatively easier as at the moment and obviously in subsequent weeks. Now the flow rate that you can achieve here is something in the range of about 1 to 6 liters per minute. And how much is the FiO2 that you can generate in this case? Then it hovers between something between 24 to 48%. Now how to remember this? 1 liter is 24% FiO2 I'm talking about. If it is 2 liters, you need to add 4. That will become 28%. If it's 3 liters, it will become 32%. Like that, at 6 liters, it would be 44%. So that's the amount of FiO2 that you are generating. And apart from this, I have also taken a separate lecture in which I have explained the concept of awake proning. So you are going to start awake proning in any patient having a oxygen requirement of more than 2 liters per minute. I reiterate my statement. One, would you go in for awake proning? That is when the FiO2 of the patient is more than 28%. I just explained to you the correlation, that is at 1 liter it's going to be 24%, at 2 liters 28. Just keep on adding 4 and you will derive these values. So this is what is commonly being used, and in fact nowadays even at home, oxygen concentrator with help of a nasal cannula we are able to deliver and maintain oxygen saturation. But lots of time persons or patients would be requiring hospitalization, so we talk about step 2. Now in step 2 there are 2 ways by which you can handle your patient. One way is the standard method that you can be using the Hudson mask, the standard oxygen mask that you can see at the moment, or in place of that you could be using a non-rebreather mask. And for both the exam perspective as well as just refreshing our knowledge, we have to remember regarding the flow rates that we'll be giving here and the FiO2 that can be generated. Do remember the fact that from the MCQ perspective, the non-rebreather mask can generate the maximum amount of FiO2. In fact, if they ask you how much FiO2 can be generated with a venti mask versus a non-rebreather mask, please remember that venti mask is a high flow system, non-rebreather mask is a low flow system. So the impression of lot of doctors, and I have seen, a lot of medical students, is that it is high flow system that will generate a higher FiO2. No, that is not the case. Please don't be under an impression that only a high flow rate can generate a rather a higher value of FiO2. Rather, a non-rebreather mask, I repeat again, is a low flow system, but it can generate a FiO2 of as much as 95%. In contrast, when it comes to a venti mask can generate something in the range of about 40 to 60. So the point is, it's not about high flow versus low flow. These are two separate concepts. One is the flow rate, second is going to be the FiO2 generated. Both cannot be correlated. And just to keep things simple at the moment, I want you to remember non-rebreather mask can generate FiO2s going up to 95%. Obviously, with a high flow nasal cannula, you can generate up to 100%. But we are talking about the conventional modalities which are available in our peripheries. Now, how much is the flow rate that you would be using in this case? This is going to be in the range of approximately 10 to 15 liters per minute. With a Hudson mask, it's something in the range of about 6 liters per minute. So obviously humidified oxygen, because if you don't use humidified oxygen, bronchospasm can definitely be a trouble. The FiO2 that you would be giving here is in the range of about 40 to 60%, and along with that, I'm just using the short form AP, that is awake proning, which I've already sensitized you to, and I've already used a lecture on the same, is to be remembered. Now the point is, in this step 2, what is the cutoff? I mean, that's the important highlight of this discussion, that at what respiratory rate, what SpO2, what PF ratio would you decide to go for step 2? Because one possibility is patient came initially with the stats which I mentioned in step 1, and then he deteriorated, so you went in for step 2. But sometimes in the casualty directly you could be having somebody who might be requiring step 2. So what would you count to decide whether person requires a step 1 intervention versus a step 2 intervention? The respiratory rate of the patient, if is in the range of 24 to 28 per minute, don't be rigid about it. I mean, it's not only about the respiratory rate, it's about the general condition of the patient. You obviously need to look at nasal flaring, you need to look for intercostal recessions, you need to look for the prominence of the sternocleidomastoid, so that would obviously matter. Now, if the SpO2 to the patient is less than 90%, and that is what is happening at the moment, most patients who are coming to you, they may not be complaining themselves of shortness of breath, but their SpO2 is reduced, the respiratory rate is definitely relatively faster. So what are you going to do? If available, you would calculate the P by F ratio. If it's less than 300, as I've explained to you, or the SpO2 FiO, or the SF ratio less than 315, it's time for step 2. In this case, my patient's GCS is okay, at least able to respond to my commands. When I'm talking to him, he's able to nod his head, he's at least able to say yes, no. So yes, the GCS of the patient is fine, and the vitals are at the moment preserved. There might be a bit of tachycardia, there might be a bit of sympathomimetic stimulation, there might be sweating occurring in the patient due to sympathomimetic stimulation, BP might be slightly even on the higher side, and you very well know a lot of these patients are hypertensive. But my point at the moment is that if I'm having stable vitals, the GCS of the patient is normal, but he is still having features of acute respiratory failure, and these values are satisfied, that is when you would deploy either of the two. And according to the AIMS MOHFW protocol, you would have noticed me saying that preferred at step 2 would be a non-rebreather mask with which we can generate FiO2 of the range of about 95%. But you have used this for, let me say, 2 hours, and there is no improvement in the condition of the patient, then you will escalate to step 3. Now, in case the same patient, the respiratory rate is jumping up, and I said, don't be very rigid about the values of the respiratory rate. They can oscillate a bit, right? Or you can take an average. Point is, if you're having consistently, you have already used step 2 for the patient, but SpO2 is still less than 90%. The respiratory rate of the work of breathing of the patient has increased. The P by F ratio is obviously less than 300, something in the range of about 150 to 300. The patient is still able to respond to your commands. The BP is still being maintained, but because the work of breathing of the patient has increased, so I move on from a non-rebreather mask to either a high flow nasal cannula or a non-invasive ventilation. Now, how do I select for the two? Point I want you to remember is, in case you find that the carbon dioxide values in the body of the patient are elevated, then in those circumstances, it is NIV that is preferred. In fact, there are certain scenarios that I want you to remember, especially for non-invasive ventilation. One, I want you to remember that if somebody is a documented case of COPD, then non-invasive ventilation is recommended. Similarly, if a patient is having cardiogenic pulmonary edema, lots of time because of the D dimer being elevated, there's a possibility that there could be clot formation. This clot could be affecting the coronary circulation, so patient could land up in possibly a myocardial infarction. So if there's a cardiogenic pulmonary edema, if it's a very obese patient and there's a documented history of obstructive sleep apnea, like he uses a CPAP machine, then in those circumstances you definitely need to intervene. My point is, if in the exam he does not mention all these points, he just makes you select between a high flow nasal cannula versus a non-invasive ventilation, and this is the I would say the respiratory status of the patient, then the first answer of yours in the exam would be high flow nasal cannula. I repeat the fact once again, high flow nasal oxygenation, or it might be written as HFNO, it might be written as HFNC, but the point is that this would be mentioned superior to NIV, but there are certain situations where NIV is superior. Now, what are those? As I highlighted, it could be COPD patient, cardiogenic pulmonary edema, obstructive sleep apnea. In fact, I would like to add one more, even post extubation. You can give support for a few days with non-invasive ventilation. We will talk about indications for elective intubation in the case, but once he's off the invasive ventilation part, then NIV can definitely help this patient recover and reduce the work of breathing. Now, in a high flow nasal cannula, you all would have seen the device in your hospital. The flow rate will definitely be, I would say, much faster. So you would be using about 30 to 60 liters of oxygen per minute. And when you use that kind of, flow rates, then there's a high possibility of aerosol generation. So I'm writing the word AGP, which means aerosol generating procedure. This can generate aerosol for healthcare workers. So it's always a good idea to ask the patient to put on a mask. I repeat the fact once again, if a patient is put on high flow nasal cannula, you are supposed to instruct the patient to put on a mask. The FiO2 that you can generate here is about 100%. And well, what is the main mechanism of high flow nasal cannula? I mean, how is it so successful? Obviously, it will eat away into your oxygen supplies, and oxygen is in short supply nowadays. I agree to that. But the point is, high flow nasal cannula can generate high FiO2s. So if they ask you in one single word, how does this work? You will say that the mechanism of action of high flow nasal cannula is that it generates extrinsic PEEP. See, you are giving a high flow, so the nasopharyngeal dead space is almost obliterated because everything is rushing in faster. So you're generating a extrinsic PEEP for the patient in the range of about 4 to 6 centimeters of water, and this has been documented to show a definitive reduction in the work of breathing. In fact, you will notice that the respiratory rate of the patient will reduce the workload of the patient. There was flaring, there was sternocleidomastoid working over time. All the work of breathing of the patient will reduce once he's put on a high flow nasal cannula. But this is absolutely contraindicated in case of hemodynamic instability. If you're having a patient who's having disorientation, if you're having a patient who's going into multi-organ dysfunction and the BP of the patient is crashing, then a high flow nasal cannula is definitely not for the patient. Now we will decide whether HFNC is working for the patient or not. So whether it is working or not, you need to remember that we generate what is called as ROC score, and this would help us determine whether the efficacy, I mean, I understand it is efficacious device, but whether it is working or not, or should you go in for a urgent intubation? Because I don't want you to have that superior feeling that, okay, I put my patient on FHNC, so I have bypassed the step of intubation. No, we are just trying to reduce the work of breathing at the moment. If the patient responds, it's okay. If not, then obviously invasive, I would say intubation would be required. In the ROC score, I want you to remember this mathematical equation, and you can apply this multiple times in case you are having this in level 3 cares of yours. That is SpO2 FiO2 ratio, whatever was the mathematical value on admission, you have to divide that by the respiratory rate of the patient. So let me just put in some values for you so that you become relatively comfortable. Suppose at the moment, though you are using a high flow nasal cannula, the SpO2 of the patient is 80%. The FiO2 that you are generating is 100%, which will be written as 1. So it would be 80 by 1. And the respiratory rate of the patient, let me say at the moment, is 30. Just for calculation purposes, I'm saying. So all you will do is 80 divided by 30, and you will have a mathematical value of something in the range of about 2.6 or so. And this value has to be calculated multiple times. I shall now be showing you a slide for ROC score. And why do we calculate ROC score? As I explained to you, is to decide whether HFNC is working or is it failing over time. You don't need to remember these mathematical values which are calculated at 2 hours of usage, 6 hours, 12 hours. But the point is, if you can just remember a rough figure of 3.47 or lesser at 6 hours, that means this is not working and you will have to plan a mechanical ventilation for the patient. You will have to anyway intubate. Now, assuming the fact that high HFNC is not available in a hospital, or let me say because of the crunch of oxygen, you see, you cannot achieve a flow rate of 60 liters per minute. So in those circumstances, NIV will definitely come to your advantage. With NIV, we can definitely be using two modalities. Either we can use a CPAP or we can use a BiPAP. Now the difference I can just represent graphically is that CPAP would be generating a constant pressure over both phases of respiration, inspiration as well as expiration. But when it comes to BiPAP is relatively more commonly used, and in this you would be having variable pressure in inspiration as well as expiration. So you would have seen a lot of settings being written, no, like 10 by 5, 12 by 6. So what they mean by 10 by 5 is inspiratory positive airway pressure. EPAP basically means expiratory positive pressure. Usually we start with settings of 10 centimeters of water and 5 centimeters of water. The main concept is that BiPAP, I'm not saying that it is gonna be superior to HFNC. What I'm saying is that if nothing is given in the MCQ, then obviously high flow nasal cannula is recommended as an answer. But in circumstances where there's a carbon dioxide retention in the patient, yes, bi-level positive airway pressure, where we have this variation of pressures generated in inspiration and expiration, is the one which is to be used. There can be a little bit of discomfort associated with it, substantial amount. So let's have a look at the flow rates that you would be generating here, and the FiO2 value of the patient as well. So with respect to NIV in a patient, usually the FiO2 that you will be generating will be in the range of about 40 to 100%. It can obviously vary, and our objective is, to generate a pressure support of something in the range of about 15 centimeters of water. The PEEP is usually kept in the range of 5 to 10 centimeters of water. Now the objective of generating the PEEP is to mainly recruit the alveoli, because the alveoli are collapsing. I want to increase the surface area available for gas exchange per se, and the flow rates can definitely vary. I mean, you can vary, and you can rather be having lower flow rates required in NIV as compared to that for HFNC. My main message at the moment is that in both the situations, either of the two that you're using, your objective should be to titrate to obtain a SpO2 at least 92 to 94% for your patient. Now, obviously, these mathematical values will become mind-boggling for you. So, I would suggest you that in the first listening to this particular discussion, I would like you to remember the parameters that I mentioned for step 1 versus step 2 versus step 3, and then subsequently, you can start remembering the data for either of the two as well. Non-invasive ventilation is definitely not recommended in patients who cannot maintain their sensorium. If there is a high risk of aspiration, if a person is having low GCS, then this technique can definitely not be used. In fact, there's a separate lecture in the app where I have specially spoken regarding invasive mechanical ventilation in comparison with non-invasive ventilation. So you can go through that, and that would definitely help you in broadening your horizon. Now, let me say that you have exhausted these current resources and your patient is not improving. Then in those circumstances, you definitely will have to upgrade to step 4. So when are you gonna go for invasive mechanical ventilation is again both a multiple choice question and a query from a lot of doctors. The message is, if you're admitting a patient right at the moment and the respiratory rate of the patient is in excess of about 35 per minute, the SpO2 of the patient is turning out to be 90% or lesser. So you can see, I'm not talking about SpO2 70% or maybe 60%. I'm saying that, yeah, the person is deteriorating. And what I mean by deteriorating is that in this particular case, the PF ratio, mark my words there, earlier the PF ratio was between 150 to 300. Now I'm saying that if the PF ratio is less than 150, it means that the person will require a intubation. In case you do not have a P by F ratio, in a sense that you don't have a ABG, though it's unlikely, because after all you're gonna be intubating a patient, so you need to have a ABG facility in your hospital. But just for academic purposes, if he says S by F ratio, then this value less than 196 is again a point where you would go in for intubation. At this point of time, the GCS of the patient will definitely start falling. Hemodynamic instability will start coming in. The blood pressure of the patient will start falling, and it might be so that he might even start having renal shutdown. You might have to use vasopressors for these patients. That is when ARDS protocol is to be used. There's a separate lecture on ARDS in the app that you will have to listen to it. The objective of this particular discussion is mainly to sensitize you to how do you escalate per se. Like for example, how much is the peak plateau pressure that I would be generating in this case or deploying in this case? That is approximately 30 centimeters of water. But all these things will definitely make more sense to you in case you go through two particular lectures. I would say, I mean, listen to ARDS, listen to invasive mechanical ventilation in comparison with non-invasive ventilation from the app. This is primarily to explain to you when do you step up or when do you step down. The SPO to the patient should be kept in the range of about 88 to 95%. So we are a little lenient at the moment. We will also be allowing what I can say is permissive hypercapnia. Now, permissive hypercapnia is again a concept which is beyond the scope of the discussion, but you can understand if there's a permissive hypercapnia, it will contribute to respiratory acidosis. That is why the pH of the patient is not 7.35. I'm not being too aggressive. I can allow a pH in the range of about 7.30 to 7.35. Neuromuscular blockade, proning is definitely recommended. This would be proning for about 12 to 16 hours per day, and this is different from the awake proning that I have explained earlier. Then is a recruitment maneuver where we will be deploying higher pressures, peak plateau pressures to recruit more alveoli, increase the surface area and improve the general status of the patient. But let me say you have tried everything that I have explained to you at the moment and your patient is not improving, then it means that your person will definitely be going into impending respiratory failure. Now, when do I say impending respiratory failure? Carbon dioxide of the patient is rising dramatically. I mean, the person will start having carbon dioxide narcosis. There could be a possible asterixis occurring in a person. If a patient is intubated, he is already on the ventilator, but still the carbon dioxide values of the patient is rising. You also notice that there is a desynchronous breathing in a sense that either there could be paradoxical breathing developing, like the abdominothoracic versus thoraco-abdominal pattern of breathing. I mean, you know the normal pattern of breathing, so what I'm saying is paradoxical breathing is coming up in the patient. Then this implies that your patient is not responding to your treatment. Our objective is mainly to ensure proper saturation of the patient within the values that I have explained. And let's just summarize the aspects. You would start off with a nasal cannula, then you can go in for a rebreathing mask, then you can step up to a high flow nasal cannula, and then you can go in for an invasive mechanical ventilation in the patient. I have explained to you the usual flow rates that you would be using and the FiO2 values for each one of these. And now the point is, when would I make the decision of stepping up? I mean, how would I decide whether I need to step up or not? So there are two things which I want you to remember. One is the ABG report of the patient, which is important. The second is the clinical observation. In clinical observation, I will not only be having, inputs in the form of the vitals of the patient, but even the work of breathing, the usage of accessory muscles of respiration. So based on these two, over a matter of 1 to 2 hours, like I have put my patient on high flow nasal cannula, not improving, I calculate the ROC score, move on to invasive procedure, that is endotracheal intubation, or if I admitted somebody on a non-rebreather mask. Now within 1 to 2 hours, I mean, the query of a lot of doctors was within how much time should we decide for a step up escalation. The KGMU guidelines mention about 1 to 2 hours based on two main parameters: the clinical evaluation, which incorporates multiple things as I explained, and obviously the ABG status of the patient. And in case all this is not done, the patient will go into impending respiratory failure. And as I have highlighted, decision of making, going up for step up or step down, I said it's 1 to 2 hour period that is required. And what would be the target SpO2 that you need to obtain? Then there are different values given, like somebody is saying that in the ward this much is to be obtained, in ICU this much is to be obtained. The target SpO2 of yours should be at least in the range of 90 to 94%. In COPD patients you will be relatively lesser, that is at 88 to 92. I understand this was slightly a technical discussion, a lot of mathematical values going around, and frankly speaking, most of us doctors are very bad at mathematics. At least I am bad at mathematics, so it's a nightmare to go through these values, but then we will have to be more adept at understanding all these things so that we can handle our patients better. Thank you for your patience and hearing me out. I know that you had a lot of easy things to do. I mean, you could have moved on to any comfortable video where you could have enjoyed, but I thank you for spending these minutes and listening to me, listening to the aspects that I've highlighted. And for the PPT of this entire discussion, you can mail me at marvamedicine@gmail.com, or we also have a Telegram group that is Top Educators. So I'll put up the link of I'll put up my email as well as the Telegram link in the description of this video. And in case you have liked this discussion, it would be great if you can subscribe to the channel. Thank you so much for hearing me out.